Hey guys, welcome back to my channel, The ENT Resident. Today I'll be continuing my series on tracheostomy. Today is part 2 of this series, and today I'll be discussing about the steps, the procedure of doing tracheostomy, and what is the post-operative care that you should be taking in case of a tracheostomy patient, and what are the things that you will be explaining to the patient attender who is going to take care of the patient as well. You can also now purchase my notes. I have added links in the description. Okay, so first let's get started with what is the surgical procedure here. So, first of all, you have to take informed consent from the patient or their family, and you have to explain all the complications that can possibly happen. What does recovery look like in this case, and how they would have to take care of the patient after doing tracheostomy. After you have gotten the informed consent, you should also make sure that a few things are ready before you start the surgery. So, first of all, if you're using a cuff tube, you can check the tracheostomy tube that the correct size has been given, and you should also inflate the cuff and check if there is any air leak. These are not things that you should be doing during the time of surgery, but you should be ready with these things before you have started the surgery. And if the cuff is working well, in that case, we apply lignocaine gel on the tip of the tracheostomy tube, and we keep all the ties ready so that our tube is ready to be placed the moment we are starting the surgery. And also, the second thing you need to check is if the suction apparatus is working properly, because if suddenly it stops working during the time of your surgery, that may end up being an emergency situation. So, these are some things that you should be ready with before you have started the surgery. Now, how will we position the patient? So, tracheostomy case, we place the patient in a supine position with their head and neck placed in extension. How do we do this? We place either a sandbag or a pillow under the shoulder that leads to the extension that we need, and a head ring is placed under the head so as to support it. Now, moving on to anesthesia. Usually, in case of acute emergency, no anesthesia is required, but we can use both general or local anesthesia in case of elective cases. Now, local anesthesia is usually given with 1% lignocaine with 1 in 1 lakh adrenaline, and this is given in the form of a rhomboid shape around the site of incision. Now, I'll talk about the incision in a little bit. Usually, it is given midway. So, if you look at the image over here, this is the thyroid cartilage, this is the cricoid cartilage, and then this is the trachea, and this is our suprasternal notch. So we'll palpate the cricoid cartilage and we'll palpate the suprasternal notch. Usually the incision is given midway between these 2 points, or 2 finger breadth above the suprasternal notch. Now, so this is the site of the incision. So how do we give local anesthesia here? Local anesthesia is given in a diamond like shape over here in all directions with 1% lignocaine and 1 in 1 lakh adrenaline. Sometimes, even the patient may already be intubated, so you may be performing the surgery on an already intubated patient. What are the advantages if of the patient being intubated already? First of all, is intubation decreases the intrathoracic pressure, as a result of which it also decreases the chance of bleeding during the time of surgery. Second, intubated patient also have a decreased chance of injuring the dome of the pleura, and also there is decreased chest movements during the procedure. And because the patient is already intubated, you're not in a hurry, so you can do the procedure properly in time without having any need to hurry. So, these are some advantages if the patient has already been intubated. If not, usually we use local anesthesia. And in local anesthesia, I mentioned that we give adrenaline as well. Now, this adrenaline has certain contraindications in some patients. So, in patients who have severe respiratory obstruction, where the partial pressure of CO2 is elevated, these patients are very sensitive to the systemic effects of adrenaline. So, in these patients, we'll try to avoid giving adrenaline along with local anesthesia. So we have positioned the patient, we have given anesthesia to the patient, and now let's get started with the surgery. So, as I mentioned, The incision is usually the 2 points that we need to see is the cricoid cartilage and the suprasternal notch. So these 2 points are important to be found. Either you give the incision 2 finger breadth above the suprasternal notch, or we can give it midway between the cricoid cartilage and the suprasternal notch. So this is where we give the incision. Now the incision can be a horizontal incision or a vertical incision. Now both have different advantages and disadvantages to it. First, let's talk about the horizontal incision. Now horizontal incision is a incision which is about 3 centimeter incision is given horizontally midway between the cricoid cartilage and the suprasternal notch. This incision is usually preferred if we are doing an elective case of tracheostomy. Advantage of this incision is that it will have a better scar. So there is better cosmosis involved here because the skin lines are all placed horizontally. So the scar formation would be better over here. But the horizontal incision has a lot of other disadvantages, like it can lead to more bleeding. In case of horizontal incision, you end up creating a lower flap where secretions can accumulate, and that increases the chances of infection happening. Also, in cases of horizontal incision, it has been seen that there is reduced laryngeal elevation, and also the horizontal incision does not lie in plane with all the other deeper tissues. They all lie in the vertical plane. So, these are some disadvantages you'd be facing if you do the horizontal incision. Now, coming to vertical incision, again, a vertical incision of 3 centimeter can be given. Vertical incision is usually preferred in cases of emergency. So, if you look here, this is what a vertical incision will look like. So, the advantages of giving a vertical incision is that it is much easier and faster. It lies right in the plane of the deeper tissues. The vertical incision also has lesser chances of bleeding, and also you do not end up creating any lower flap as you do this. And the only disadvantage in case of vertical incision is that it leaves behind a disfiguring scar. So that is about our first step, which is the incision. We can give a horizontal or a vertical incision, and we discuss the size of the incision and the location of the incision to be given. Now, after we have given our incision, the next step that we need to do is we'll deepen the incision. So, one by one layer will come the skin, subcutaneous tissue, superficial fascia, and then the investing layer of deep cervical fascia. So, we'll deepen the incision through all of these layers and separate them out. Important factor to remember here is that we should keep a lookout for the anterior jugular vein. We should not end up damaging causing injury to the anterior jugular vein, because that can cause a lot of bleeding. So, where do we find this anterior jugular vein? Usually, they'll be seen on either side of the midline. So, as we have reached and we have separated the deep cervical fascia layer, next layer that will come is the strap muscles. The two strap muscles that you have to separate in the midline are the sternohyoid and the sternothyroid muscle. So, after we have separated them, our next step comes on to thyroid isthmus retraction. So after we have separated the strap muscles, this is what it will look like. So we'll see the thyroid isthmus lying in this region. So now we identify the thyroid fascia and we dissect of the thyroid fascia, and then we have the thyroid isthmus. Now there are two ways to deal with the thyroid isthmus. One option is that you can just clamp the thyroid isthmus with a hemostat and divide and ligate it. The second option would be retract. We can just retract this isthmus either superiorly or inferiorly and expose of the trachea. So these are our two options in dealing with the thyroid isthmus. Now, as we have dealt with thyroid isthmus, either we have retracted it or divided and ligated it. The structure in view would be our trachea. So what will we do here? We'll have to identify the trachea. So first we'll palpate the tracheal rings and we know that okay, we have reached the trachea. We'll differentiate it from the cricoid cartilage which lies above. Then we'll dissect off the tracheal fascia which lies on the trachea. Now, if you do not incise the tracheal fascia, pretracheal fascia properly, there may be air leak under the fascia going towards the mediastinum. So we have to make sure that we have dissected off the pretracheal fascia as well. Now that we have reached the trachea, how do we make sure that indeed that this is the trachea and this is not anything else? So the things that you'd be looking for, first of all, is trachea will ideally be a midline structure. Second, if you look at the image over here, you can see these white cartilaginous rings. This is what a trachea will look like. And these rings, when you palpate them, they will have a very firm feel. And you'll also be able to see that the trachea is moving with respiration. And the last way to identify and confirm it for sure is to take a syringe which is filled with saline. We'll introduce this syringe into the trachea and aspirate. When you aspirate, you'll see bubble formation inside the syringe, and that will confirm the presence of the airway over there. So, these are all the methods by which we will identify the trachea. Now that we have identified the trachea, before we make any incision, we have to make sure of certain things. Number one is if there is any bleeding point, we'll have to control all of them, and we have to achieve complete hemostasis before giving the tracheal incision. Second, we'll have to recheck that the suction apparatus with the tube is ready to be used. And lastly, we'll inject a few drops of 4% xylocaine or lignocaine into the trachea. Why do we do this? This is done so as to avoid any tracheal irritation due to the tracheostomy tube introduction, which can suddenly lead to a sudden respiratory arrest because of vagal stimulation. So, injecting a few drops of 4% lignocaine will avoid this irritation. So, now that we are ready with everything, now our next step is to give an incision on the trachea. So, incision is usually given between the second and the third tracheal ring. And this is what is known as mid tracheostomy. In my previous class, I spoke about high, low, and mid tracheostomy, and I said that the mid tracheostomy is the usual one that is followed because high tracheostomy and low tracheostomy they have their own disadvantages. You can check out my video to learn more about that. So, usually we avoid the first tracheal ring because it is very close to the cricoid cartilage. So, you may end up causing damage to the cricoid cartilage and subsequent subglottic stenosis. Now, next point is what kind of incision do we give on the trachea? Now, there are a lot of variety of incisions that you can give. Like it could be just a horizontal incision or a vertical incision, or you can have a T-shaped incision or a U-shaped incision. There can be a H-shaped incision or a cruciate incision. And sometimes we even create something known as a Bjork flap, where we give an inverted U-shaped incision, and this lower flap that is developed over here, this lower flap is sutured to the skin edge, and the flap that is formed here is the Bjork flap. Now, Bjork flap has a disadvantage that this flap can easily get displaced and end up blocking the tracheostome during the time of recannulation. And second disadvantage is there can also be an increased chance of forming a tracheocutaneous fistula during the time of decannulation. So these are some of the examples of incision that we can give here. The choice is usually up to the surgeon to decide which incision they want to give. Another point here to note is that in children, we prefer giving a vertical incision in the trachea. So this is about the incision. Now, after giving the incision, the opening that is formed in the trachea, we have to make sure that the size is optimal, that there are no ragged edges, and the incision is not a round one, because if you end up giving a round opening over here, it will lead to circumferential contraction leading to tracheal stenosis later. So these are some ideal points that you need to look about in the tracheal opening. Now, while giving the incision, what if you end up encountering some variation in the trachea? Now, what are these variations that can happen? The trachea can end up being a very soft and malleable trachea. This is usually seen in children, and stay sutures on trachea are needed in these cases. Second, if we see a hard or a calcified trachea, now this will be seen in elderly people. So, in hard trachea, sometimes you may even need to remove a part of the anterior tracheal wall, or you may not be able to incise with the usual instruments. You may need some bone cutting instrument if it is very hard so as to open the trachea. And third variation is in case of carcinoma larynx patient. In these patients, we prefer to do a high tracheostomy. So these are some variations that you may encounter. Another point to keep in mind is if it is a case of emergency tracheostomy, then we have to be very fast with performing our tracheostomy because anoxia for even 4 to 5 minutes can lead to death of the patient. Second thing to remember here is in emergency cases, we will not inject the local anesthetic into the lumen because the cough that occur can end up actually worsening the respiratory distress. And second, the anesthetic should not infiltrate the paratracheal gutter. Why? Because this will end up in causing more respiratory distress because it can lead to the paralysis of the recurrent laryngeal nerve. So these are some points that you need to remember during the time of the tracheal incision in case of an emergency tracheostomy. So we have come to the step of incision on the trachea. Now, after giving the incision, what do we do? Our next step would be to insert the tracheostomy tube. So, before that, we need to know what is the size of the tube. Ideally, in a case of female, the size is usually between 7.5 to 8 mm, and in males, it's usually between 8.5 to 9 mm. So, now after the incision, what we do is we insert a tracheal dilator into the opening that we have just made. And then we take the tracheostomy tube along with the obturator and we insert it into the opening. Now, you have to remember that the tracheostomy tube tip has to be lubricated with lignocaine jelly, which we have already prepared before we started the surgery, because otherwise it may end up causing more damage or injury to the surrounding structure. So once we have introduced the tracheostomy tube along with the obturator, we quickly take out the obturator after that. And then our job is to confirm whether we have indeed entered into the trachea or not. Now, how do we do that? There are some ways that we can see whether we have entered the trachea or not. First of all, is the moment you take out the obturator from the tube opening, you'll get an air blast coming from there. Second, we can auscultate the chest to see for air entry into both the lungs. Third, we can perform a cotton wool test. What is a cotton wool test? Here, we take a cotton wick and we take it in front of the tube opening. The air blast that is coming from the cotton, that is coming from the tube, will end up moving the cotton wick. So, this is the third way to confirm. Fourth is we can also do an X-ray neck or chest later to demonstrate the tube. So these are some ways that we confirm, okay, indeed we have placed the tracheostomy tube in the trachea. Now that we have done that, our next step would be to secure the tube and aspirate any blood, mucus or secretions that might be there. Now, what are some reasons why, despite placing the tube in the right place, the patient is not able to perform respiration? Now, there are reasons behind this as well. First reason could be maybe the vagus nerve got stimulated and that led to sudden respiratory arrest because of the irritation by the tube. Second is sometimes there can be central respiratory failure. Here, what happens is the respiratory center of the patient who has been in hypoxic levels, they get used to high levels of CO2 and very low level of oxygen in the blood. Now, as soon as tracheostomy is done, the oxygen level in the blood quickly rises and the CO2 levels falls. This can lead to depression of the respiratory center, and this is known as central respiratory failure. Third cause of not getting respiration despite placing the tube in the right place is when there is a false passage of tracheostomy tube created. And fourth, if the tracheostomy tube itself is blocked, which is why it is very important for you before you start the surgery to make sure that the tracheostomy tube is working properly. Now, our next step would be to secure the tracheostomy tube. How do we do that? So, when we are performing a tracheostomy, right after that, the tube that we insert should always be a cuffed tracheostomy tube. Now, the cuff that is present has now to be is now to be inflated with about 3 to 5 ml of air. So, you take a syringe of about 5 to 10 cc and you push in air to inflate the cuff. And this cuff usually ends up lodging between the fourth to the seventh tracheal ring. So you have inflated the cuff. The next step would be to now fix the tube in place. Before you fix the tube, first we'll relieve the neck extension that we had placed the patient in, and then we'll tie the tape around the neck in such a way so that it's not too tight or not too loose. So it shouldn't be loose because otherwise the tube can get accidentally extubated out, and it should not be too tight too. So you should be able to pass just one finger in between the tape and the skin of the neck. And very rarely, sometimes you may also need to do suturing of the skin if the incision that you placed is more than required. So, this is how we'll secure the tracheostomy tube. And after this, we'll perform a keyhole dressing where we'll place a gauge piece around the flange, around the stoma, so that there is no friction in between the tube and the skin of the neck. So that completes our steps of the surgery. Now, moving on to our next part, which is very important, and that's post operative care after tracheostomy. Now, this is something that is very important. You need to explain to the nurse and the patient's attenders as well on what care needs to be given after the patient has undergone tracheostomy. So, first of all, after the introduction of the tracheostomy tube, the patient cannot speak. So, for that, you should keep a paper and pen near the patient so that they are able to communicate through that. And if there is no patient attender around all the time, a bell should be provided to the patient in case they need any assistance, they'll be able to call through the help of the bell. Second is humidification. Now, I spoke about this in my last class where I said that one of the physiological effects as a result of tracheostomy is that usually in a normal person, when we inspire air through the nose, this air gets filtered and humidified while it's passing through the nose. But in case of a tracheostomy, we completely end up bypassing this pathway. So, as a result of which, the air is not getting humidified before it reaches the lower respiratory tract. So, the dry air that is reaching here now can end up in encouraging crust formation and decreased ciliary action. How do we combat this? We have multiple ways to do this. We can keep a wet gauge piece around the tube or over the tube to help in humidification. We can even use the heat and moisture exchanger machine, which is the HME machine. We can even use a nebulizer. And if we do not have any of the above, we can keep a boiling kettle in the room. This will help in increasing the humidification, but this is not preferred because this will end up in soiling the clothing as well. So, humidification is a very important part of the post-operative care in a tracheostomy patient because otherwise the dry air will end up causing a lot of crust formation. Next is suctioning. This is another important aspect that we have to understand how to do. So now that the tracheostomy tube has been placed properly, the next thing that you have to do is make sure that secretions are continuously removed by suction. Now, what is the frequency at which we should do suctioning? Every half hourly in the first 24 hours, and thereafter every 1 to 2 hours, depending on the case. So, there are a lot of things in relation to suctioning that you should know. First of all, is what is the size of the suction catheter that we should use? The size of suction catheter in French is found out by a very simple formula, which is the inner diameter of the tracheostomy tube multiplied by 3 and divide the whole thing by 2. For example, if the size of the inner diameter is 8, then 8 into 3 by 2, which is 24 by 2, which means you have to use 12 French suction catheter. So this is how you find out what is the size that you should be using over here. Now, what is the procedure of doing this? So, usually, since we have placed the cuffed tracheostomy tube in the patient, first step would be to first deflate the cuff. Then we'll attach the suction catheter to the source of negative pressure. For adults, is usually 100 to 150 Hg. Then we'll end up lubricating the catheter tip with some lignocaine jelly so that it doesn't cause irritation as it's entered. Now, you don't just directly enter the catheter. The first thing you should do is you should know what is the length of the tracheostomy tube that has been placed in the patient. That is the amount of catheter that you will be inserting inside. You should not insert beyond that. So, when the patient is approaching the peak of inspiration, you'll block the eye hole in the catheter so as not to suction it, and then you'll insert the catheter inside the tracheostomy tube. And at the end of the incision, you'll unblock the hole that you were covering, and you'll apply the suction and withdraw the catheter in a very rotating motion. Now, it is important to remember that every time you suction, it should not be more than 5 to 10 seconds at all. And at a time, you can only suction for 2 to 3 times only. Now, after you have finished suctioning 2 to 3 times, you'll auscultate the chest after suctioning and reinflate the cuff. So, this is how we'll perform suctioning of a tracheostomy tube. Now, in case usually we do not require to any normal saline, ringer lactate, or any other solution to be placed inside before suctioning. But if you see that the secretions are very thick, in that case, what will help is you can either pour some saline or some sodium bicarbonate inside before you start suctioning. These things will help in thinning out the secretions. So this is all about the suctioning part, the size, how do we determine the size of the suction catheter, and what is the procedure at which we do, and what is the pressure that we should maintain. Next, moving on to the other parts, how will we take care of the tracheostomy tube change? Now, tracheostomy tube change should not be done immediately because once you've performed the surgery, it takes about 5 to 7 days at least so that epithelialization of the tract can occur. So, outer tube should not be taken out during this time. However, you can take out the inner tube out to clean it and place it back. So, the inner tube cleaning should be done 3 to 4 times a day for the first 2-3 days, and then you reduce the frequency of this. How do we clean it? We take it out, put it in a bowl of hydrogen peroxide, make sure that we take out all of the secretions that are inside the tube, and then keep it under running tap water and clean it up. And once the cleaning is done, we'll dry the tube before we insert it back. So this is how we'll take care of the tracheostomy tube change. And after 7 days, we can change the tube from cuffed to an uncuffed one if required. Next is the stoma care. Stoma is the point, if this was the trachea and this is where the incision was given, this is the stomal region. So you have to take care of the stomal region by changing the dressing on the skin that you place around the around the stoma underneath the tracheostomy tube. This dressing needs to be changed every day, and you should clean the area so that there is no granulation formation or no crust formation over there. You should also look for any skin changes that might be occurring over here. Look for any infection of the skin over here. And if there is infection, we can apply antibiotic ointment over here to deal with it. Next is, how do we deal with the inflatable cuff? So I mentioned that we have placed the inflated cuff. Now, how do we keep it cuffed at all time, or do we deflate it and inflate it? So this cuff that we have placed, if we do not deflate it from time to time, it can end up in causing tracheal stenosis. So therefore, the protocol over here would be to deflate the cuff every 1 hour for 5 minutes and then re-inflate it to prevent any tracheal stenosis. Next is about the nutrition. Now, usually we'll encourage the patient to be on oral feed, but if it is not possible, then we make sure that the nutrition is given by parenteral nutrition. And lastly, we should also take care of the oral hygiene. Just because we have put the tracheostomy tube does not mean that's the only area that we should be taking care of. The oral hygiene is also equally important. So this is how we will take care of the patient in the postoperative period in a case of tracheostomy patient. And all of these needs to be explained to the person who will be taking care of the patient, whether it's a patient attender or the nurse, about all of these. And it is very important to follow each one of these instructions. So that's all about how we perform the surgery and what is the postoperative care looks like and how will we suction the tracheostomy tube. In my next class, I'll be discussing about the complications of tracheostomy.